were born on a glorious day, my Yusuf, my Yusuf. Even stars in the sky shied away when the tears in my eyes fall like rain from the skies, and the love that you bring, pretty flowers in spring, and the hopes and the fears shatter 7 long years for a father to be. Never thought would be me.
But when Allah set you free and He gave you to me, like I wish and I pray, in heaven you are made.
And how I cried through the night, hoping everything's alright. Oh, I used to be so forlorn till the day you were born. You saw, baby, come to me. Little streams will join big rivers in time. Little hopes and dreams, baby knows it seems. Now I smile all the time, singing nursery rhymes, and the wind and the rain seem to whisper your name.
But when Allah set you free and He gave you to me, like I wish and I pray, in heaven you are made.
And how I cry through the night, hoping everything's alright. Oh, I used to be so forlorn till the day you were born. You saw, my baby, come to me. You were born on a glorious day, my Yusuf, my Yusuf. Even stars in the sky shied away when the tears in my eyes fall like rain from the skies, and the love that you bring, pretty flowers in spring.
Assalamu alaikum wa rahmatullahi wa barakatuh to our listeners on this Saturday morning on Radio Al Ansar 90.4 and Peter Marisburg 105.6 FM. I am Shubnum Ismail on the Pmb Pulse Show, capturing the heartbeat of our community. And today we're honored to have Dr. Howard Wain, a distinguished general surgeon and subspecialist trauma surgeon, as well as a trauma intensivist. Dr. Wain's impressive medical journey began with his undergraduate education in medicine, and he completed a few modules as well, which he was assigned then to Pietermaritzburg. Dr. Wain's dedication to his craft is evident in his further specialization in general surgery, which he completed in 2020. Shortly after, he joined Harigwala Regional Hospital as a surgical specialist, where he's not only made a significant impact in his field, but also played a vital role in educating interns and surgical trainees. His academic contributions extend to serving as a lecturer at the University of KwaZulu-Natal's Department of Surgery. As a member of Trauma Level 1 at a local private hospital, Dr. Wain's expertise in trauma surgery and critical care shines through. His passion for research has led to notable achievements, including an award in 2020 for his master's thesis and analyzing surgical adverse events. Dr. Wain has also recently completed his PhD focusing on defining the role of error in adverse events in a referral surgical department in South Africa. And outside of his profession accomplishments, Dr. Wain is grateful for the love and support of his wife and two young sons. We're very excited on Ansar Pietermaritzburg to tap into his wealth of knowledge and experience today. Welcome, Dr. Wain.
Good morning. Thank you, Shubnum, for having me here today.
I know that you've got a very busy schedule, and it's really, really nice to have you this Saturday morning with us. Listeners, today we're shining a spotlight on a critical and often overlooked topic, burns. We'll be discussing the latest advancements in burn care, the importance of prevention, and what you can do to protect yourself and your loved ones. From first aid to long-term recovery, we'll cover it all. So let's get started and explore the world of burns with Dr. Wain this morning as our guide. So Doc, let's dive straight in. What are the most common causes of burns and how can they be prevented?
So we see quite a few different types of burns that come to us, and it definitely varies by age. So in children, we tend to see a lot of burns that are accidentally happening around the home. So they may have hot water injury, where the small child has reached up and pulled on a tablecloth where there's a cord of a kettle or something like that. We see accidents, so that's a hot water burn. Okay. We see accidents related to in and around bath time, again with hot water and kids not understanding the danger of hot water. We see also in kids, we see flame burns where their little boys play with fire as they do. And then we see electrical injuries as well. Okay. And then obviously there's a crossover where we see in both children and in adults, we see flame burns or fire burns from house fires or felt fires or things like that. Obviously, we do see hot water burns in adults as well, but they seem to be more common in children. And then in adults, we also deal a lot, and we see this a lot here locally, is industrial accidents. And those are obviously work-related injuries. And that can be from any industry. It can be chemical burns, it can be hot liquid burns, it can be flame burns, it can be electrical burns with electricians and that. So we see a very broad range. But to answer your question, I'd say the most common would be flame burns. The flame can start from any number of things, obviously, but then and then hot water as well. And then in the adult population, certainly work-related injuries.
So obviously working in ED, you get the patient arriving and obviously you got to categorize as burns. Do you want to highlight how you categorize them?
Yeah, so there's a few ways we categorize them. We look at firstly, how the burn happened, because that impacts what we might need to do immediately. So for example, if it was a chemical burn, we might need to wash off that chemical. But otherwise, we categorize it. So we refer to flame burns, hot water burns, hot gas burns, electrical burns, chemical burns, those kinds of things. And the reason that we categorize them is because of the associations with other injuries. Electrical injuries and flame burns are probably the most common there, where we see other injuries associated with the skin burns, which I'm sure we'll get to talking about later.
Yes.
And then we also have to think about the severity of these burns, and that takes a little bit of work to get to that distinction of what's a milder burn and what's a more serious burn. And we don't tend to use the word mild, moderate, and severe. We tend to talk about the percentage of the burn, so how much of the person's body was burnt. And so then we use those kind of how it happened, how long it was since it happened, and how much of the person's body has been burnt. And that really helps us understand how severe it is.
And obviously, you do get patients coming in with severity of burns. And what are some of the signs and symptoms
of a severe burn?
Yes.
Yeah. So anything, and this depends which book you read, and it changes a little bit with the age. But in general, any burn to more than about 15% of the body is immediately considered to be severe. Any burn that was accompanied with a burn to the face then puts the patient at a very high risk of having what we call an inhalational burn or an airway burn. And that makes it far more severe. And then somebody that may have had some kind of associated trauma with the burn. So, for example, they had a car accident and then the vehicle caught on fire. So, yes, they've got a burn, but also they've got an injury in their brain, they've got a broken leg, they've got abdominal injuries. As soon as there's something else now in conjunction with the burn, that immediately makes it more severe and those signs of it. So the people that how they present to us is if they walk in and they say, I burnt my hand on the stove, well, you kind of get an idea that that's not so severe. But if they're brought in by an ambulance and they're not fully conscious, so they're not breathing well, their heart rate's very fast or too slow, and their oxygen saturations are very low, those are very worrying signs of it being much more severe.
Yeah. The next question, I'm actually smiling because I'm thinking about my childhood. If you had a burn, your mom says, go put a little bit of Colgate or butter. And, obviously you deal with so much of burns coming through to your ED. What are the first steps that one should take in terms of initial care?
Yeah, so I must say, you're right. You get these crazy recipes that people put on these burns. And it's sad, I think, actually, because the answer to your question is so simple. And it's one sentence. It's 20 minutes of cool running water. And that's it. So we don't want ice. That makes things worse. We don't want egg and oil and butter and various creams. You mentioned toothpaste is on the list. We've seen some chemicals. I've seen Jay's fluid and dishwashing liquid and all sorts of really funny things that come from just a lack of understanding. The best answer, and in fact, I think the only answer to your question is, like I said, 20 minutes of cool running water. And that seems to have a benefit up to about 4 hours post the burn. So it actually has value for quite a long time.
Yes.
And what we're trying to do there is the middle of the burn that's already been badly injured. There's not really much that we can do about that. What we're thinking about mainly with that first aid is the area around that middle portion, because that's the area of the skin that's probably salvageable if we can cool it down fast enough. And so that's what we're targeting, and it works.
And Doc, the first 24 hours is really crucial of getting a patient to an ED for assessment and treatment. If it's not treated, can you probably tell us what could be some challenges for the patient?
Yeah, so untreated burns, obviously it depends really on how severe the burn is. If it's a really large burn, in north of 30% or 35%, that person probably won't survive for 24 hours without intervention. And it's because they get quite dehydrated. So in the big burns, there's not going to be many long-term consequences because, unfortunately, that person's not going to survive to be around for long-term. But of the smaller burns, scarring is mainly the bad one. And the scarring can come in many different forms and is usually because these burns don't heal. And so then they require perhaps unnecessary surgeries that could have been avoided. The other thing that's a big problem that we see in burns, especially when they're delayed, is infection. The skin, a normal human skin, is the most fantastic barrier to infection. It's an amazing barrier between this outside world, which is full of bugs, and the inside of us, which is relatively clean. And our skin really is what creates that barrier. Now, with the burn, that barrier is lost. And so, for various reasons, we're now not able to fight off both skin infections, and then our bodies are so busy fighting the skin infection that we're more at risk of other infections as well. So pneumonias and urinary tract infections and all sorts of things become far more common. So delayed burns are very bad. The pain, obviously, as well, can cause long-term psychological issues because burns are very sore. We all know that. We've all burnt ourselves. Fortunately, most of ourselves have not had a bad burn, but we all know how sore it is. And if it's not managed properly, that can go on to cause major psychological issues later in life. And so those are the kinds of biggest complications we see of delayed or neglected burns.
Yes. So, doctor, how do you manage pain in burn patients? And what are the most effective pain management strategies? I mean, I'm trying to visualize. I mean, I've done some work in ED before, but not as an ED specialist. And, you know, you're getting your patient coming in as a P1, P2, and obviously it's burns related, the anxiety, trying to comfort the patient. Can you give us a scenario on the steps that your team will take in order to stabilize the patient and treatment thereof?
Yeah, sure. So the management of pain in burns and analgesia in burns, as we call it, is quite a complex thing, actually, and it's vitally important to get it right, as you mentioned. I think the easiest way to think about it is to break it up into various components. So the first thing is, as you mentioned, when the patient first comes in, what we need to do there is we need to get an idea of what's going on with these burns. So we need to do any first aid needed. And by first aid, I mean that we do cold running water in hospital. We don't even do anything fancy. We also do running water.
Okay.
And again, that emphasizes how effective it is. That also helps with pain. So if somebody comes in with a fresh burn, cool running water helps with pain. We can all attest to that ourselves. You put your burnt finger under the tap, it feels better. So we do that. Then the painkillers that we give, there's lots of different options. But to broadly categorize them, we can give tablet form painkillers, we can give intravenous painkillers, we can give inhaled painkillers in some situations, and we can give topical painkillers. Now, the topical ones tend to not work so well. They're topical as in the ones we put on the skin. But a very good topical painkiller, not designed as a painkiller per se, but it works, is to expose the wound, clean it nicely, and get it dressed. Okay. We all know as well from our own experience that if you cover a burn, it feels much better than if it's open. So we like to cover burns early with appropriate high-quality dressings. Then our pain strategy, it definitely takes two arms. So the first is that these patients have a background level of pain. You know, they're lying in the bed, they're moving a little around a little bit maybe, and it's a bit sore. So we have to give a certain amount of painkiller just 24 hours a day. Now, whether that's usually in tablet form, sometimes in an intravenous form as well. And then we have to think about when we need to do a procedure. So when we need to change dressings, when we need to put up special lines, when we need to move them or bathe them. Sometimes we need to give them extra painkillers. And so we call that procedural sedation, and we use short-acting shorter acting medications there for that. So it's a complex thing, painkilling in burns, analgesia in burns. It's a very complex thing, and it has to be done properly. Otherwise, the outcomes are worse. So, yeah, we spend a lot of time thinking about pain in burns. Yeah.
You spoke about procedures, and obviously you work with a multidisciplinary team,
Yes.
such as your plastic surgeon. You probably will bring in other surgeons to assist and assess the wound. Can you tell us a little bit about this and obviously effectively communicate on the patient's journey to ensure you're getting the desired outcome?
Yeah, so the patient obviously has to be fully aware of what's going on, and we do spend a lot of time talking to the patient themselves about what we're expecting, and just creating a reality for them that this is, if it's a big burn, it's a long journey. This is not a 3-4 day thing and then they're going home. This is a long journey. Then we involve a whole multidisciplinary team, as you mentioned. So we involve occasionally we do involve plastic surgeons. That's a little bit different maybe in KZN to in other places. Where in other places, I know in Johannesburg, plastic surgeons deal a lot more with burns than they do here in KZN. And that's not right or wrong, it's just a bit of a local difference. So the general surgeons and trauma surgeons deal a lot with the actual skin side of it themselves. Then we involve ICU teams in the big burns that assist us greatly with all of the ICU management, and there are lots of challenges with ICU management issues in burns. Then we use dietitians, physiotherapists, occupational therapists, speech therapists, sometimes a little bit delayed if somebody's not been eating for a while for various reasons. Psychologists are massively important in burns. You can imagine a patient with a huge burn, this is a terrifying thing that's happened to them. And the emotional well-being of somebody is really important. And in fact, we see it when their mind clutches out, their skin gets worse, and when their brain comes back online and their emotions improve a little bit, all of a sudden their skin follows suit. So we do need everybody, and we've all got our areas of expertise, and we all bring that to the party, and we get some good results, but it has to be a big team sport. And importantly, I think, and this is what I think we do very well locally, is that the trauma surgeon is the one that drives this whole process. Not the one who's in charge necessarily. That's the wrong wording, I think. But the one who is the team leader in many ways, and kind of will bring in correct people at the correct time, and then maybe ask somebody to step back at a certain time if they're not really needed at that point. And then kind of guide where the patient is, how often they go to theatre, how often they have dressings. So that the surgeon, the trauma surgeon, really kind of is well positioned to guide that whole process, and then be the team leader, for want of a better word.
And speaking about expertise, has there been any advancements with modern technology to probably assist with burn care for patients?
Yes and no. I think we are probably getting better at understanding the major body-wide impact of a big burn. We've historically, I say we, humanity and medicine as well, have historically thought of burns incorrectly as being a skin problem, whereas in fact it's actually a whole body-wide problem that's generated by a skin injury. And it's an important distinction, because yes, the skin is burnt, and certainly we can see that, and families can see that, and patients can see that, but there's actually every organ in the body gets affected by this, and that's on the background of a lot of inflammation that happens after a big burn. And so a lot of our advances actually are not really all that clever, and they're not all that technologically wonderful, but they're really just getting some basic principles right early on that makes big differences going forward. So we spoke a bit about analgesia, pain.
Yes.
So getting that right from the beginning, getting nutrition right from the beginning, and there's lots of ways we need to tackle that. Getting the wound care right from the beginning, getting psychology involved from the beginning, in that first kind of 1 to 3 days, getting the amount of fluid that this patient needs right, getting them moving early so they don't get contractures where they get stiff, all those things. So we're not really doing anything that's particularly amazingly clever. We're just doing some of the basics right, and we're quite aggressive with doing certain things correctly right from the beginning. and that seems to make a really big impact. Certainly, there are some very nice new dressings that are available, and there is a lot of technology that's coming into burns now, and a lot of science that's coming into burns now. But really, those are for the minority of patients. Actually, the majority of burns patients will do well if we just do a whole lot of small, basic things right from the beginning. They do much better.
Listeners, you tuned into the Pulse Show with myself, Shubnum Ismail. We're going to take a short break with a soulful nasheed to uplift and inspire this Saturday morning. And when we return, we'll be back in a flash with conversation with Dr. Howard Wain, a dedicated trauma surgeon in our city of choice, Pietermaritzburg.
الهدى سيدي ومن بعده الأربع الخلفاء محمد نور الهدى سيدي ومن بعده الأربع الخلفاء لك الحمد يا ربنا وكفى فصل وسلم على المصطفى وآل وصحب كرام له هم السابقون وأهل الوفاء وآل وصحب كرام له هم السابقون وأهل الوفاء لك الحمد يا ربنا وكفى فصل وسلم على المصطفى هو المجتبى من هدينا به فيا رب زد أحمدا شرفا هو المجتبى من هدينا به فيا رب زد أحمدا شرفا لك الحمد يا ربنا وكفى فصل وسلم على المصطفى فإن القلوب تهيم به وإنا نذوب به شغفا فإن القلوب تهيم به وإنا نذوب به شغفا
حن قلبي لبيت ربي حن قلبي لبيت ربي أطوف وأسعى سبعا سبعا أطوف وأسعى سبعا سبعا وخلف مقام إبراهيم صلاة الله وتسليم وخلف مقام إبراهيم صلاة الله وتسليم
لديار الله أمضي أطلق الرحلة أدخل الميقات شوقا أبدأ الغسلا ألبس الإحرام حتى أحتوي معنا وأصلي ركعتين قربة لله أقصد البيت العتيق وألبي في الطريق ربي لبيك فقد جئت من فج عميق جئت يا ربي إليك عبدك بين يديك
Assalamu alaikum wa rahmatullahi wa barakatuh to our listeners on this beautiful Saturday morning here in Pietermaritzburg. We are on Radio Al Ansar 90.4 and Pietermaritzburg 105.6 FM. You are with Shubnum Ismail on the Pietermaritzburg Pulse Show, capturing the heartbeat of the community. Joining me today is renowned Dr. Howard Wain, a highly respected trauma surgeon in the city of Troyes, who is also an intensivist with a wealth of experience in general surgery and trauma care. So, Dr. Wain has worked at prominent institutions both in the public and the private sector, also a lecturer at the University of KwaZulu-Natal's Department of Surgery. With a strong passion for research and education, Dr. Howard Wain has significant contributions in the field of trauma surgery and critical care. Welcome again, Dr. Wain.
Thank you.
So, Doctor, tell us, what are the most common complications associated with burns and how can they be prevented?
So the biggest complications we see with burns are infections are a major problem with burns. Pain is a problem. Scarring certainly is a problem. And then related to scarring is something called contractures. And that's really where the movement around a joint becomes limited because the tissues around it, which are usually very soft, are now almost rock hard in some situations. So that's really kind of related to scarring. The other thing that the other complications which we see, and these fortunately are not common, and we were chatting about this a few minutes ago, is amputations. And we do unfortunately sometimes have patients that lose fingers or arms, hands, feet, legs. And fortunately, that's not common, but it's definitely one of the more unpleasant complications from burns.
How can we prevent infections with burns if it's not treated properly? What could be the repercussions?
Yeah, so infections and burns are kind of in two big categories. There's skin-related infections, which are in many ways almost inevitable with the burn. We often speak about in burns, and maybe it's a little bit cynical of us, but we kind of say, well, it's not if there's going to be an infection, it's when is there going to be an infection. And here I'm really talking about in patients that are in hospital and those with bigger burns. We know that they're going to have infections. It's a matter of fact. What we spend a lot of time doing in our admitted patients, and particularly those in ICU, is looking out for signs of burn sepsis and then treating it early. The things we can do to avoid them is regular wound care, and the definition of regular will change depending on what dressing we're using, but appropriately regular wound care. We need to deal with things like care of invasive lines, so intravenous lines or central venous lines, care around catheters, urinary catheters in some patients, care around tubes that maybe we're sort of breathing through for the patient in selected severe patients. There's a whole lot of things that we do, and those are referred to as bundles of care. We go through these steps every day, and the nurses are really pivotal in this, in going through these steps every day to care for those lines well, so that the infections from them are less frequent. And then when we get into theatre, we obviously do a whole lot of disinfecting so that's related to skin type infections and those then related to them. So there doesn't seem to be any evidence that giving antibiotics up front actually prevents infection. So what we'd rather do is do what we can without medications to prevent infections. But when they do come, we're actually quite aggressive with treating those infections, because if they get out of control, that can be very severe, and in fact is oftentimes the cause of a burns patient passing on, is that there's infection that we can't treat.
Yes. And tell us, how do burns affect the psychological well-being of patients, and what support mechanisms are in place to help them cope?
Yeah, so, that's a really important thing to think about, and it's probably something that we, to be honest, should be doing better at. So the psychological impact on the patient, this is the person who themselves have got burnt, is they're now confined to a hospital bed. Again, I'm talking about a major burn here. They're confined to a hospital bed often for months on end. I mean, I've recently been involved with a patient who's been admitted for more than a year. That's a very long time to be away from family and home, and that's devastating. So fortunately not usually that bad, but we are looking at prolonged admissions, usually measured in weeks, not days. So they're away from their usual support structures. We've got then issues related to now and often, especially if it's an industrial accident, you've got the person who was the breadwinner for the family who's now not working. And so that then places a massive financial stress on them. Then they're worried about cosmetic issues, and are they going to be disfigured? Are they going to be dysfunction? Can they get back to work? Can they get back to their family? Will my kids recognize me? Will my wife love me? All those issues, and these are very important psychological issues which patients deal with, and we don't always know about them well, which is why we certainly here locally we've got a good relationship with an excellent psychologist here locally, and we involve her very early, because she's like a magician. She can get these things out of these patients that they'll deny to us, but she gets them out. And then, so that's a very important support structure. We also understand that the patient's family is hugely pivotal in their burns journey. And so we try and involve them as much as we can. We keep them updated about what's going on. But the truth is that we tend not to interfere or intervene with family dynamics, because it's not, we just find ourselves walking down a rabbit hole which we can't escape from. So, but if the person has a supportive family, and if the person already has support structures, we definitely help them to utilize those. And so we'll often facilitate phone calls, or we'll facilitate visits if we can. When patients are a little bit better and they're maybe needing wound care, but they're not in ICU, we certainly will help to try and facilitate them maybe getting out of the hospital for a morning to go and visit with a family member or something. So there are structures in place. We probably don't utilize them as much as we should, and certainly something we've been speaking a lot about recently here is focusing more on those things, because it's a very big deal.
I know you spoke about wound care, so let's unpack that a little bit more. Has there been any advancements? You obviously deal with different companies and have to use the right approach to get the desired and the best outcome. Do you want to touch on that a little bit?
Yeah, sure. So look, I mean, the wound care side of a burn is very important. Unfortunately, one of the people that taught me, she's a very, very prominent burn surgeon here in Maritzburg. In fact, in South Africa, Nikki Alorto. She's a wizard with burns. And one of the things I remember her saying is that there's a lot more art than science in wound care. And what she means is that there's no defined recipe that works for every single patient. And so what ends up happening is that you need a lot of experience to understand that, okay, I've started with dressing A, it's not working as well as I perhaps thought, so I'm going to move to option B. Or, wow, option A is working wonderfully, I'll continue with that. So, and that takes quite a lot of experience, and unfortunately can't really be taught to somebody outside of them just learning it with you in co-managing a patient. There are certainly some very nice dressings available. I'm not going to punt any particular dressing, because I don't think that's appropriate, but there are some great dressings available. Some of them are very absorbent, so they keep the wound dry enough but not overly dry. Then in some burns we want dressings that provide a bit of moisture, so then they'll keep the wound moist but not too wet. There's other dressings that have painkillers in them, so they can deliver painkillers directly to the wound, although we don't use those often. Then there's the antibacterial or bacteriostatic ones, where they help to clear infection. And those are what probably forms the mainstay of what we use. And those, a lot of them contain silver and some other substances that help to be antibacterial. And then, not that this is a dressing per se, but we're now starting to get access more to particular cleaning agents that we can use in theatre and certain disinfectants. Some of them are very fancy, and some of them are just diluted vinegar. That works very nicely for some infections. Wow. Yeah, and then in the real kind of in the far more advanced sphere of burns and burns dressings, we've got synthetic skin substitutes, which we're using more and more, and to very good effect. We're learning more how to use them and when not to use them, and those really help the burns to heal better by themselves and not need surgery, not need skin grafting, which is great for scarring. And then even more than that, we've got there's a product called ReCell. We take the patient's tissue and it's sent to a laboratory, and their own cells are grown and put into a spray form and then get sent back to us.
Wow.
In a spray form, and then that can be applied onto the wound. Obviously, as you can imagine, the fancier it gets, the more expensive it gets. And so that actually brings us to another point, is that burns care is very expensive.
Is that similar to skin transplant?
So a skin transplant, what we do is we actually take the patient's, a skin graft, we take the patient's own skin, and we obtain a very thin layer of skin using a special instrument, and then we put it through a machine or one of two machines, and that allows us to then apply it onto the burnt area. Then the place where we took the skin from heals, because we took such a thin layer, and then the burned area also heals. That's a skin graft. A skin transplant, yes, it's spoken about. There are a few cases there where, for example, a mom has donated skin to her child, and there are a few situations where that skin is actually taken and grown on the baby. But usually what happens is that skin really just acts as a really high quality dressing for a few weeks while we get the patient in a better condition to do a skin graft with their own skin.
Yes. Speaking about kids and toddlers, I'm assuming that you also deal with the younger and the minors that actually come in with burns. How's your management, and do you prefer dealing with adults, or you're obviously skilled enough to deal with different categories of patients?
Yeah, so we do deal with and we do accept and manage burns in children as well. They are very challenging. It's this, from an emotional standpoint, it's a lot easier to look and to deal with an injured adult. But dealing with an injured child, it just seems so much more, it's a lot more gut-wrenching, So that's a lot more emotionally challenging for us and for the whole team that's involved. And then, of course, we've got a very worried mom and dad who also then have, they've got millions of questions, and they're good questions and they're very valid, but it brings in another whole challenge which you don't really have with adults. But yes, certainly we do manage children with burns. The principles are much the same. The principles are, get the fluid right early, get feeds going early, get physio and OT and dietetics involved early. Psychology, definitely. Obviously, the very, very little ones, a couple of weeks old, psychology is not so important, but for mom, absolutely. The psychologist has a far more difficult time with kids than with adults, because they're dealing with baby and with mom and dad. So she works very hard with babies. But yes, we do, and the principles are much the same, and we have actually had many great outcomes with burnt kids. So yeah, we do, but they're challenging, very challenging.
I have the utmost respect for you guys as trauma surgeons and arriving at ED, and you're not sure what to expect, and not only burns, you're dealing with motor vehicle crashes, gunshots, and different severities of patients coming in. But obviously your burn patient is coming in. Have you dealt with a patient that came in with other comorbidities, and how would you deal with that?
Yeah, so definitely. I mean, the reality is a large portion of our population has comorbidities. and a person with comorbidities is just as likely to get burnt as anybody else. Interestingly, we found far more burns in epileptic patients than those that aren't epileptic, which is interesting. But how we deal with that? Well, ideally, we try and manage all of these things simultaneously. So we try and manage the burn at the same time as we manage the diabetes and the high blood pressure and the thyroid that's misbehaving and maybe the cancer that they've also got and all these things. We try to manage them all together. Occasionally, we have to allow one thing to take preference over another. And that's usually with injuries, not so much as comorbidities. Because comorbidities are long-term, they're chronic, and they've usually already got some management in place, and we just continue it and then fine-tune it as we go along. But when somebody's got another injury at the same time, like a head injury or a fractured leg or whatever they've got, that then can become quite challenging as to which do you allow to take priority, because in some situations, to treat the one well, you might make the other one worse. And that's a very uncomfortable situation, and we don't see it often, but when we do, sometimes we have to make tough choices. And for example, focus on the brain and allow the brain to recover and then deal with the negative consequences that happen to the skin, rather than having a beautifully healed skin and a brain that can't recover. So sometimes we have to make choices, but usually we try and manage everything all together. And if needs be, we'll involve other disciplines. So if somebody's got a thyroid problem, and we might involve a physician to come and assist us with that, because it's outside of our area of expertise.
Wonderful. So, Doc, you spoke about psychological impact with the patient, and obviously the amount of expectation. You're in the world of saving lives. Psychologically, obviously, how do you deal with your own personal emotions when you get the patient coming to ED, and you've got the multidisciplinary team, you've got the ED team, and your patient has arrived, and you've got to get everything smooth sailing because everyone's relying on you to keep your finger on the pulse and ensure that patient, its time is of essence. So how do you deal with your emotional well-being?
Well, to be honest, there's many situations where you've just got to man up and get on with it. And that's it's not a clever answer, but it is just the answer that I've got, is that sometimes you just have to get on with what you got to do. Certainly there's the emotional aspect of it. And definitely the healthcare providers, whether it's us as the surgeons or the nursing staff that see the patients far more than we do, especially in ICU, or the OTs and the physios and the dietitians, all of us get affected by this, and especially when things are not going well. And the reality is burns and big burns are bad for you. And so sometimes patients pass on. And sometimes we have to allow that to happen. It can become very difficult. And there are some support structures in place. Again, psychologists play a heavy role here. I feel sorry for the psychologists because they're supporting everybody else, although I'm sure they've got their own support structures. But we've got a lot of us rely on our families a lot, not necessarily to debrief or talk about it, but just to be a safe space away from work that we can just go and get back to a normal life, And I think the important thing for us to remember as healthcare providers is that this is what we chose to do.
Yes.
This is it is our passion. It is what we chose to do. We don't always like it because it's tough, but we do have to do it. And in fact, we take a lot of comfort knowing that the families and the patients are relying on us. And if they see us kind of composed and having it together, they often take a lot of comfort from that. And so we draw a lot of strength from that. But it's not always easy. It's easy to talk about, but it's not always easy to live.
I'm sure and I hope that Almighty gives you all the strength to carry on with your work. As listeners, we come to the wrap of today's discussion on burns and trauma. I want to thank Dr. Wain for taking up a lot of his time this morning, for sharing his expertise and insights with us. And definitely we're going to have you again on the show to unpack different areas of trauma. Sure. There's snake bites, there's gunshots and different things. And it's clear that prevention prompt treatment and proper care can make all the difference in outcomes for burn patients. To our listeners, we encourage you to prioritize fire safety, be aware of potential hazards, and know what you do in case of an emergency is very important. So, thanks again, Dr. Wain, for joining us. Your knowledge has been invaluable. And how can listeners get in touch with you? And any final words to end the show today?
Yeah, I think just the final thing to say is that if burns are managed early, the outcomes can be very good. But if they're not managed well from the beginning, the outcomes can be bad or even disastrous. So I would encourage people that do sustain burns to seek appropriate care early. And in the Pietermaritzburg area, which is where we are now, the Netcare St. Anne's Hospital has a level 1 trauma unit there, which I'm involved with. And there's lots of other experts there as well. In fact, a lot of my trainers are there. And we really would readily accept anybody that comes there with burns. There's an emergency department specialist as well, more than one, who also is involved with burns care and assists us a lot with the initial care. So if people sustain burns, particularly bigger burns, I would encourage them to come through to Netcare St. Anne's, to the emergency department, and we will take it from there. We do this all day and every day. And we've unfortunately, or fortunately, depending on how you look at it, we've had lots of practice. And we can't promise a perfect outcome, but we can promise that we'll deliver the best care we can to get somebody back up and running again.
Thank you, Dr. Wain. Definitely an expert in your field, and it's been amazing having you on our show. To our listeners, shukran for tuning in today's episode of The Pulse. Healthy choices, better futures, and our motto here, we believe that taking care of your health is one of the most important investments you can make. Jazakallah, assalamu alaikum, and thank you to our technician and our team in Pietermaritzburg and Durban for connecting with you, the listeners. Inshallah, have a beautiful weekend and Saturday. Assalamu alaikum wa rahmatullahi wa barakatuh.
حن قلبي لبيت ربي حن قلبي لبيت ربي أطوف وأسعى سبعا سبعا أطوف وأسعى سبعا سبعا وخلف مقام إبراهيم صلاة الله وتسليم وخلف مقام إبراهيم صلاة الله وتسليم